just yet, so I'll just make a preliminary announcement about a change in the program. When I talked to my co-presenters for this next section, we discovered that we had 2.5 hours of material to present in about the next 75 minutes. And so I've made an ad hoc change here. Dr. Mark Hickeson will make a presentation first, and then we'll have the second presentation by Dr. Muller-Brandt. And if there's a little bit of time left at the end, I will give you a telescopic message, sort of an ex cathedra statement by virtue of my being in the chair about the situation of some of these diagnostic and therapeutic isotope situations in Canada. So with that, I'll introduce Dr. Hickeson, who is here in native now in Montreal, and a nuclear physician at the McGill Education and Hospital System.
Okay, thank you very much for the invitation. It's a great pleasure to have the opportunity to present in front of all of you. Okay, what we're going to talk over the next 30 minutes or less is what is the role of imaging modalities with radionuclide for neuroendocrine tumors. And a great deal of the talk is going to be about, with somatostatin analogs, which will be the emphasis. But we're also going to talk about FDG, PET imaging, and MIBG. So I'd like to give you a brief introduction. What is a SPECT-CT? It's a hybrid system that combines the acquisition of SPECT data with cross-sectional radiographic data. The SPECT and the CT images are almost obtained simultaneously. Well, the SPECT images demonstrate the function, while the CT provides anatomical landmarks. So I'd like to also give a brief history. The mathematical models of tomographic images were published by a mathematician by the name of Johan Radon in 1917. But the first SPECT image was actually successfully accomplished with an Anger camera by Dr. Kuhl at the University of Pennsylvania and Dr. Edwards. The first CT was actually done by Dr. Hansfield in 1972. In the year 1981 was the year where there was software image fusion of anatomical and functioning imaging modalities. But the first prototype of a SPECT-CT was actually built at UCSF in 1990. And this became first available commercially in 1999, and this system was the GE Hawkeye camera. But further improvement occurred. In 2004, the first commercially available SPECT-CT system with a multi-slice CT scanner was made available in 2004. Now, today, the three major manufacturers of SPECT-CT hybrid systems are with GE, Siemens, and Philips. They all produce very good cameras. So let's start with octreotide imaging. So this is the structure of somatostatin. It is a hormone that has 14 amino acids. It also exists in the 28 amino acid form. This hormone is present in the hypothalamus, the cerebral cortex, the brainstem, the gut, and the pancreas. It is known as the generalized inhibitory hormone, and what is characteristic with somatostatin, it has a very short half-life in the plasma of 3 minutes. So somatostatin is not a suitable agent for imaging because of the very short plasma half-life. But there are longer analog with longer serum half-life that are more suitable for imaging. And there are 5 somatostatin type receptors, 1, 2, 3, 4, 5. And there are multiple somatostatin analogs that are available in the world. In Canada, we use indium pentriotide, known as octreoscan, which is analog for octreotide. And octreotide is much longer acting than somatostatin. Among all the 5 receptors, octreotide has the highest affinity to type 2 receptors, followed by type 3 and type 5. And the affinity profile for the 5 different subtypes can be summarized on this table. And we see here, this is octreotide. The lower value means higher affinity. And please take note that there are other radiopharmaceuticals that are in development, which include one that is labeled with gallium-68, Dotatok, which is, has almost 10 times higher affinity to the type 2 receptors. Octreotide with octreoscan is a very good radiopharmaceutical, but there are new there are studies that are or investigations for even better radiopharmaceuticals. And in Europe, they're very advanced in this regard. Okay. Now, the clinical impact of SPECT-CT on one study with 11 abnormal, 18 abnormal result, and there was a change in management in 7 of those 11 abnormal patients, with 4 being major change in management, meaning a change from surgery, curative surgery to palliative, or surgery to radiation. That's what defines a major change in management. And minor change means just you have one type of surgery, you change to another type of surgery, or you just change chemotherapy regimen. So diseases that may be visualized by somatostatin imaging. You have neuroendocrine tumors, other tumors, and non-neoplastic disorders. I'm going to concentrate mostly on neuroendocrine tumors. And there's a large list of them. The majority of neuroendocrine tumors tend to be slow growing, but there's, you see at the bottom of the list here, small cell lung cancer is very aggressive. So there are some exceptions. And this table actually summarizes the sensitivity of all of various neuroendocrine tumors with octreoscan. And most of the neuroendocrine tumors have a very high sensitivity. But this is a very small sample size in most of those individual type of tumors, with maybe the exception of carcinoid, which is much more common. But please take note that insulinomas have less than 50% sensitivity, maybe 42%. And thyroid, medullary thyroid cancer and pituitary adenomas have also mediocre sensitivity with octreoscan. Other tumors, I'm just going to mention, they can be imaged as well with octreoscan, and that has been done with lymphomas and non-small cell lung cancers. And now the false positive, non-neoplastic disorders that can mimic tumor. You have autoimmune disease, granulomas, you have thyroid-associated ophthalmopathy, post-radiation sequela, bacterial infections, and you also need to be aware of physiologic activity at multiple sites that can mimic disease that you need to be aware of. Well, this is the protocol that has been that a lot of investigators use. Well, we actually use a lower dose. We use about 3 millicuries to decrease the radiation dose to the patient. A whole exam gives about 18 rads or 1.8 rads of radiation. So if you have the dose, you decrease it to 1.2. The CT setting is a very low dose CT scan. just the 2.5 MA, which is 2 orders of magnitude approximately lower than the diagnostic CT scan. So we're trying to minimize the radiation to the patient. Now, all patients, they're imaged at 4 hours and 24 hours because, which means the patient need to come for examination for 2 days. But it's such a expensive radiopharmaceutical. Octreotide costs more than $1,000 per dose, so we want to make sure that the patient gets the maximum benefit with this examination. And at 4 hours, the advantage is that you have negligible biliary and bowel activity, which I will exemplify later. And at 24 hours, you have lower background activity, which results in a higher tumor to background ratio, or better detectability of tumors. And well, the dose of a whole study is 18 millisievert or 1.8 rem, which is the spleen and kidneys are the critical organs that has the highest dose. So let me start with a few cases. This is a 33-year-old with a pheochromocytoma. And there's the planar images, and we demonstrate disease in the chest, in the right thorax, and also in the right proximal femur. And we did a CT spec acquisition for more accurate localization. And then we obtained this with a focus activity that's actually localized in the right rib. There's a bit of breathing motion, so the images are not perfectly registered. And there is also a lesion in the sternum. So that's a case of multiple bone metastasis. Second case is a patient with a resected uterine neuroendocrine tumor. And at 4 hours, the scan looks completely normal. But here we see the gallbladder being very hot. So it's very easy to, particularly if you don't have the CT, and we just do a 24-hour picture, we can get very confused by this intense gallbladder activity. Okay, third case. It's a 55-year-old with resected carcinoid of the ileum. Again, there's a 4-hour picture, a 24-hour picture, and I'll show you on the tomographic images. At 4 hours, looks completely normal, and at 24 hours, you have activity in the hepatic flexure that can mimic activity or disease in the inferior surface of the right hepatic lobe. So 4 hours and 24 hours pictures are very important. And we see here. The fourth case is a 70-year-old with a history of islet cell tumor. And the 4 hours this time looks completely normal, but the 24-hour pictures, we show a subtle lesion that we did a diagnostic contrast-infused CT scan. Well, we see lots of background activity in the spleen and elsewhere in the liver, but when we show the diagnostic CT scan and we see right here that this is indeed a octreotide avid lesion that's only seen at 24 hours. Well, what happened here? Okay, a 43-year-old with neuroendocrine tumor of the ileum. Now, this patient has multiple ultra-tight avid lesions consistent with liver metastasis. What I want to point out is that the level of the thoracic inlet on the left side, there is a lesion. Well, could that be in the thyroid? Possibly be in the thyroid. This is a multiple endocrine neoplasia can get thyroid neoplasm. Let me actually show you just this picture here, and we don't know whether this lesion is located in the thyroid, or is it in the lymph node, is it in the bone, or the left lung apex. So we did actually the SPECT CT, and indeed this shows that the lesion is localized in the left transverse process of the C7 vertebra. So this is a bone metastasis that was confirmed on SPECT CT. Okay, so I'm going to talk very briefly about MIBG imaging. It is an analog of neuroepinephrine precursor, which concentrates in the presynaptic secretory granules of the catecholamine-producing cells. It is an acceptable alternative imaging modality for neuroendocrine tumors. The problem is that there is limited accessibility. The iodine-123 MIBG would be a much better radiopharmaceutical, with better imaging and dosimetric characteristics. However, MIBG with iodine-131 is the only one that is commercially available in Canada. And one disadvantage is that thyroid blockade with potassium iodide is required, and it should be started a day before MIBG injection at 3 times a day for 5 days to protect the thyroid gland. That is important not to forget. What happens due to autoradiolysis, you have the free iodine that is released from MIBG, and that will go to the thyroid gland and ablate the thyroid gland without the blockage. That's not a good thing. And then there's many drugs that need to be stopped because they interfere with MIBG uptake, and that needs to be done for up to 21 days. And the drugs that and medications that block MIBG uptake includes many of the hypertensive medications, tricyclic antidepressants, symptomimetic, antipsychotics, cocaine, and opioids. Oncologic indications for detection, staging, and restaging of neuroendocrine tumors, and to evaluation of tumor uptake to determine whether it is suitable to treat with high doses of iodine-131 MIBG or iodine-125 MIBG. And is to also used to confirm for suspected tumor derived from neuroendocrine tissues. There are several MIBG-avid neuroendocrine tumors, which include the pheochromocytomas, neuroblastomas, and as well as carcinoid tumors, but there are others as well. This is a 1.5-year-old with a left adrenal mass. This is the iodine-131 MIBG study. Does not look very beautiful, not as high a resolution, but we can see that the left adrenal gland is actually MIBG avid, and then that was subsequently biopsied and proven to be a neuroblastoma. Okay, we'll finish with positron emission tomography. What is positron emission tomography? It is a non-invasive imaging modality which uses positron-emitting radioisotope to produce three-dimensional pictures of tissue in the body within and monitor metabolic or physiologic activity. The most commonly used radiopharmaceutical is fluorodeoxyglucose, which is the sister of glucose. It is known that tumor eat up sugar more than normal cells, and that has been known for more than 70 years. And so FDG is an analog of glucose, and it is retained in the cell because it reflects the initial step of glycolysis. So you have glucose and FDG in the extracellular space that enters the cell into the glucose transporter molecules, and FDG is phosphorylated into FDG6 phosphate due to the action of hydrokinase, and the main difference with FDG and glucose that it is not further metabolized in the glycolytic pathway. So this results in the retention of FDG into the cells. And but there's a small amount of FDG that can be dephosphorylated by glucose 6-phosphatase and exit the cell again. So this is how a healthy person looks like on the PET scan. And one thing to note that the patient has a lot of reactive sugar that is excreted into the bladder. And the patient is not, he does not have glycosuria, the patient is not diabetic, it's just that the kidneys are very smart organs. They can differentiate between glucose and FDG. The brain is even fooled, even consider FDG as being glucose. So in the sense that the kidneys are smarter than the brain. Okay, next slide. Okay, patient preparation. Patient must be euglycemic at the time of the examination, must have normal blood sugar. High blood sugar is associated with decreased detectability of the lesions, and the patient must fast for at least 4 hours prior to the study. If the patient is hyperglycemic at the time of the study, with a glucose level greater than 10 millimoles per liter, and we simply reschedule the patient. And the patient should be relaxed and do minimal activity after FDG injection because FDG will be taken up in the muscles that the patient used. Okay, FDG in neuroendocrine tumors. The majority of neuroendocrine tumors tend to be slowly progressive. There are functioning neuroendocrine tumors that have affinity to somatostatin analog or MIBG or both. However, there are aggressive tumors that tend to be more FDG avid and less avid to somatostatin analog and MIBG. FDG activity is associated with high proliferation of tumors. So there's a patient with an atypical carcinoid. It's a 78-year-old. Here's the baseline scan. There was multiple quiescent lesion on the liver. They're still very abnormal, but they're not hypermetabolic on PET. Okay, so the patient had a repeat scan almost 2 years later, and there is a new lesion that is evident in the left hepatic lobe that was not there before. So this has grown over 2 years period of time, but it is mildly FDG avid. So this is a metastatic carcinoid. Okay. Okay, sorry. Oh, next slide. Oh. Okay, I'm just going to finish with a patient with small cell lung cancer who has diffuse skeletal pain. Just to illustrate, small cell lung cancer is a very aggressive disease. It's even the bone scan looks unremarkable, but the PET scan, it shows very extensive disease throughout the skeleton. This is small cell lung cancer, and it's a very aggressive malignancy, and it's very intense on PET. So I'm just going to finish with the conclusion. Imaging with somatostatin analog is the first-line radionuclide imaging modality for neuroendocrine tumors. MIBG imaging is an acceptable alternative imaging modality for neuroendocrine tumors if ultrascan is negative, and the diagnosis of neuroendocrine tumor remains clinically suspected. And FDG uptake is associated with a more aggressive clinical course. Okay, thank you very much.